Hello, hello. Welcome back, everyone. And I hope every one of you is doing good. I'm sorry for the delay. I get stuck in the traffic. I'm sorry for any inconvenience. Okay. All right. So I just drive for 6 hours and I get some traffic. So I was stuck in the traffic. So that was the reason I'm actually late for 40 minutes from my scheduled time. Is it? So sorry for that. Okay. All right, so we're going to start our class now. And how many people have joined? Okay, so I will just wait for 1 more minute for others to join, then we will start. All right, so I'm going to start my class. So I think we completed till the aortic dissection. And yesterday we couldn't do a quick class because I went somewhere in the event. Okay, so let's do the subclavian steal syndrome now. Subclavian steal syndrome means what is happening in the subclavian artery. Subclavian, subclavian, steal syndrome. So it's called subclavian steal syndrome. It means something is wrong with the subclavian artery. Is it? So something is wrong with the subclavian artery. So before that, I would love to draw the arch of aorta. Will be my arch of aorta, and this is arch of aorta. So this picture is very important to understand the subclavian steal syndrome. Okay, so this will be my right side. This is my right side, and this is my left side. Okay, so on the right side, I get what? I have the brachiocephalic trunk. I have the brachiocephalic trunk, and brachiocephalic trunk give rise to the right subclavian artery. So suppose I say this is my right subclavian artery. This is my right subclavian artery, and this is my left subclavian artery. This is my left subclavian artery. So right and the left subclavian artery, they give rise to what? The right subclavian artery give rise to right vertebral artery. And you guys know that right vertebral artery runs on the right side along the vertebral column. So this will be called my right vertebral artery. Is it? Right vertebral artery. And this will be called my left vertebral artery. Left vertebral artery. And you guys know that left vertebral artery and the right vertebral artery, they combine with each other in the middle. So this will be my right vertebral artery coming, and this will be my left vertebral artery coming. So they both combine together in the middle. Can anybody tell me what's the name of the artery which is being produced by the combination of these two arteries? When they combine at the base of the brain,
Basilar artery.
very good, they become a basilar artery. So this become a basilar artery. So basilar artery is a combination of what? Right and the left subclavian artery. And basilar artery supply the brain to your medulla oblongata and the bones. Is it? And the midbrain as well. Simply, I would say this artery, basilar artery, supply the blood to the brain stem. Okay, it supply the blood to the brain stem. That's a basilar artery. Now, this diagram is very important to understand the subclavian steal syndrome and the symptoms of subclavian steal syndrome. So, what is subclavian steal syndrome? Means subclavian artery is stealing the blood. It's actually stealing the blood from other artery. So, we are going to discuss that. What is the cause of subclavian artery? The cause of subclavian artery could be the stenosis of your subclavian artery before the vertebral artery. Before the vertebral artery, suppose I say subclavian steal syndrome is a stenosis of the left subclavian artery. So when your left subclavian artery gets stenotic, so before stenosis, I would like to discuss that, normally the pressure in the right vertebral artery is equals to pressure in the left vertebral artery. Suppose the pressure in the right vertebral artery is 30, so the pressure in the left vertebral artery will also be 30 because both of them receive the same amount of the blood. So pressure is normally equal. Okay. Now what happens? What happens if I get the stenosis of the left subclavian artery? If I get the stenosis of left subclavian artery, what will happen to the blood flow to the left vertebral artery? It will decrease. Blood flow will be decreased, is it? Because you are getting the stenosis proximal to the branch of the left vertebral artery. So left vertebral artery blood flow will decrease, is it? And if the left vertebral artery blood flow decreases, it means the pressure will also decrease, is it? So here you see normally the pressure was 30, but now the pressure will drop to 10. Pressure drops to the 10. So when I get subclavian steal syndrome, the pressure in the left vertebral artery, it drops to the 10. So if your pressure in the left vertebral artery drops to the 10, what will happen to the blood flow? The blood will actually flow from the right vertebral artery into the left vertebral artery. And from left vertebral artery, the blood will go where? Blood will go to the subclavian artery. So subclavian artery is actually basically doing what? Is it stealing the blood from the right vertebral artery. So right vertebral artery is giving its blood, right vertebral artery is giving its blood to your left vertebral artery. From left vertebral artery, the blood is going to the left subclavian artery. And from there, it will go to your left upper extremity. So this is called the subclavian steal syndrome, where the blood is actually moving from right vertebral artery to the left vertebral artery. Now, what are the causes? Can anybody tell me what are the causes of this narrowing of the left subclavian artery? Why does I get the narrowing of left subclavian artery? What are the causes? Very good. Atherosclerosis could be there. Very good. Atherosclerosis is actually there. Very good. What other causes? Can anybody tell me the name of vasculitis? There's a one vasculitis which involves the large blood vessels, and that is pulseless disease. It's called pulseless disease. That's called Techiasu arteritis excellent, or could be any kind of the heart surgery. When you do any kind of the heart surgery, and that heart surgery is going to do what? That heart surgery is going to, cause fibrosis near the heart. Okay. So that's actually called, these are the causes of subclavian steal syndrome. Now, how does actually patient present? What will be the typical symptoms of the patient? Symptoms of the patient. So patient is going to, so in the affected extremities, suppose in this case, my affected extremity is left upper extremity. So what will be the symptoms in the left upper extremity? I will get what? Ischemia, arm ischemia will be there, ischemia. And because of ischemia, what will I get? I will get what? Pain in the left upper extremity. There will be pain. There will be pain, and you are going to get the paresthesia as well in the affected extremities. Okay. Pain and the paresthesia. Pain and the paresthesia are going to be seen in the affected extremities. All right. Now, what happens? Now, patient will say that he feel dizzy, he become dizzy, or he feel dizzy when he actually use the affected extremity. So patient will say that whenever I move the left upper extremity, I feel dizzy. Why do I feel dizzy? Can anybody tell me what is the reason? So whenever patient moves his left upper extremity, he feels dizzy. What is the reason of this dizziness?
Because it will compress more.
Yeah, you close, Rahul. Very good. What?
Because decreased blood supply to the brain as basilar artery form between in right and left vertebral artery in a connection.
Yeah, you close.
So when
Very good.
move the right arm, then blood supply from the
Uh,
right vertebral artery goes to the arm, and right side of the brain blood flow decrease.
Yeah, very good. You close. So what happens here? You see, when I'm doing the movement, or when I'm moving my left upper extremity, what will happen? It will drop more pressure in the left subclavian artery. So there will be decreased pressure in the left subclavian artery, because when I'm moving the left upper extremity, the pressure is going to drop. So there will be more shunting of the blood. There will be more shunting of the blood from right vertebral artery to the left vertebral artery. And if you keep shunting the blood to the left vertebral artery, your basilar artery will be affected. So when you actually affect your basilar artery, it will lead to reduced blood flow in the basilar artery. And when your basilar artery blood flow decreases, it means your brainstem blood flow will decrease, and that will actually give you the dizziness. That is going to give you the dizziness, or that's going to give you the reduced cerebral perfusions. Reduced cerebral perfusion, which will present with the dizziness, syncope. So that will be the typical presentation of the patient. All right. Now, any patient who present with these symptoms, you have to confirm the diagnosis. And how will you actually confirm or make a differential diagnosis? You will measure the blood pressure. So there will be blood pressure difference of how much? There will be 15 mm of systolic blood pressure difference between two upper extremities. 15 mm. 15 mm of systolic blood pressure difference. Systolic blood pressure difference between two upper extremities. Okay. So you get 15 mm of the difference. All right. So that is actually the correct. So suppose 15 mm means in my right upper extremity, my blood pressure is actually 135 by 85. This is in the right upper extremity. Whereas in the left upper extremity, my blood pressure is 115 by 75. So here I'm getting the blood pressure difference of greater than 15 between both upper extremities. That's in the systolic blood pressure, not in the diastolic, but in the systolic blood pressure. Okay, so that will be your, that will increase the differential diagnosis of subclavian steal syndrome. But how will you confirm the diagnosis? Can anybody tell me what investigation you will do to confirm the subclavian steal syndrome? Yes, so we are going to do a CT angiography. CT angiography, yeah, your Doppler, we use Doppler. Most of the time we use Doppler for the venous, for the veins, we use a Doppler. For the arteries, we always use angiography, is it? So that's a good investigation for the arteries. All right. So that was all about your subclavian steal syndrome. And can anybody have the question regarding subclavian steal syndrome? Then I will jump to the ischemic heart diseases. Okay. All right, so that was all about subclavian steal syndrome. It's a very simple disorder. If you just remember this diagram on your picture, it's very easy. All right, now let's discuss another disorder that's called ischemic heart diseases. So we're going. Okay, all right. I'm here. Okay, so all right. So let's discuss ischemic heart diseases. Ischemic heart diseases. Okay. So sorry for any inconvenience. All right. Hopefully it will work smoothly now. Okay. So now we discuss the subclavian. We completed the subclavian steal syndrome. Now we are going to discuss ischemic heart diseases. So ischemic heart diseases. So what does it mean by the term ischemia? Can anybody define the ischemia? What's the definition of ischemia? So we're going to discuss ischemic heart diseases now. Can anybody tell me what's the definition of ischemia? Yeah, I mean, very good, Latif. Excellent. So it's actually called decreased blood flow to the tissue is called ischemia. Decreased blood flow. You cannot say loss of the blood flow. Loss of the blood flow is not a good term. So ischemia is actually defined as ischemic. So we're going to discuss ischemic heart diseases. So ischemic heart diseases means you have the decreased blood flow to the heart. This decreased blood flow could be, the blood flow of greater than 60% drop, or greater than 70% or 80%, or it could be 100%. So that depends upon the severity of the blockage. That depends upon the severity of blockage. So ischemic heart disease are there. So it actually decrease blood flow to the heart. So when you decrease the blood flow to the heart, you might get two types of the injuries. You might get the two types of the injury depending upon the severity of the blockage. So one type of the injury is called reversible cell injury. Reversible cell injury, reversible. So reversible cell injury it will only happen when your blockage is greater than 70%, but less than 100%. So blockage greater than 70%, if your arteries are blocked greater than 70%, but less than 100%. Less than 100%. So that is called reversible cell injuries. Okay. So that's actually called the reversible cell injury. Okay. I'm here. Okay. Just give me 1 minute. I'm here. All right. So reversible cell injury will only happen when you have the greater than 70% blockage, but less than 100% blockage. That's called the reversible cell injury. Okay. So can anybody tell me what is the cause of the reversible cell injury? So reversible cell injury is always caused by atherosclerosis. When you get atherosclerosis, what is the typical characteristic of atherosclerosis? It will cause what? It will lead to blockage less than 100%. It will never block the artery completely. It always blocks the artery incompletely. So that is why atherosclerosis is the most common cause of reversible cell injury. Okay. Now, what is the hallmark feature or characteristic feature of reversible cell injury? Can anybody tell me what's a characteristic feature of reversible cell injury? Yes. What?
Swelling.
Very good. Cellular swelling. Cellular swelling or membrane swelling is a characteristic feature. You just get the membrane swelling. Membrane swelling. And can anybody tell me what's the reason of membrane swelling? What's the mechanism behind it? Why I get the membrane swelling in the reversible cell injury? Yes.
Sodium, potassium, ATP stop working.
Excellent. Very
No
good.
ATP. There is no ATP.
Very good, Latif. So what's the reason why I don't have a ATP here? Yep.
Lack of oxygen.
Excellent. What happens? You get what? Decreased oxygen. And that decreased oxygen will lead to what? Decreased electron transport chain function. Decreased oxidative phosphorylation. You don't have oxidative phosphorylation. So that leads to decreased ATP. And when you have the decreased ATP, which will lead to what? Decreased function of sodium potassium ATPase. Is it? Decreased function of sodium potassium ATPase. And when you get decreased function of sodium potassium ATPase, what will happen? The sodium will accumulate within the cell. Sodium will accumulate within the cell, and that sodium will suck the water, and that water will lead to membrane swelling. So that's actually reversible cell injury. Now, when you get reversible cell injury in the heart, that is called angina. That's called what? Angina. So angina is actually what? Yeah, sure. I can repeat it for you. Okay. So what did I say? Reversible cell injury. What are the characteristics of reversible cell injury? The characteristic feature is called membrane swelling. So what is the reason of membrane swelling? Because when you reduce the blood flow to the heart, you have the reduced oxygen supply as well. So when you reduce the oxygen supply, it will inhibit your electron transport chain. And that electron transport chain, when inhibited, you get the reduced ATP, and that reduced ATP will lead to reduced function of sodium potassium ATPase. As a result, it will lead to increased sodium inside the cell. Sodium inside cell. And which will lead to what? Which is going to lead to membrane swelling. The sodium will suck the water. The water will come inside. And when the water comes inside, you get the membrane swelling. So this is reversible cell injury. And when you get reversible cell injury to the myocardium, it is called angina. angina is a reversible cell injury to the myocardium. Okay, so I will discuss what is the difference between angina and the MI now. So angina is what? Angina, you get what? Chest pain secondary to decreased blood flow to the heart. Secondary to decreased blood flow to the heart. You get chest pain. And that chest pain is due to what? Reduced oxygen supply to the myocardium. Chest pain due to decrease oxygen or blood supply to myocardium. Okay. Now, depending upon the cause of the angina, and the symptoms of angina, we have the three types of the angina being there. So first type is called stable angina. Now, stable angina is defined as what? You get chest pain with the exertion. When you get chest pain with the exertion, that is called stable angina. Okay. So that's actually called stable angina. You get what? Chest pain with exertion. And why you get the chest pain with the exertion in the stable angina? Because in case of stable angina, when you are doing exertion, your myocardial oxygen demand increases. But because of the blockage of the artery, the blood flow cannot be increased to the myocardium. So you get the chest pain. Okay. So what is the cause of this stable angina? The cause of stable angina is called the atherosclerosis of coronary artery. Atherosclerosis of coronary artery, which cause blockage greater than 70%, but less than 100%. As I discussed you here, we don't get a complete blockage. Angina is not a complete blockage. So you get what? Blockage greater than 70%. Blockage greater than 70%. 70%, but less than 100%. And that's due to the atherosclerosis of coronary artery. Okay, so that's actually the cause of the stable angina. And if any patient, if he present with the chest pain with the exertion, so what will be your first investigation in these patients? You will do the EKG. And if I do the EKG, what will the EKG show me? Can anybody tell me what will the EKG show me? In case of stable angina, what will be my EKG findings? Yes, will I
depression?
depression.
get the depression in the resting ECG? When I'm doing the resting, when my patient.
Not ST depression.
No, very good. There will be no ST elevations or ST depressions.
It will show I thought it would show ST depression, no?
Yeah, you said me ST depression, but you will get the ST depression with the exercise. I'm going to clear that to you. So resting ECG, is going to be normal. So resting, okay. So resting ECG is going to be normal. But to diagnose the stable angina, we always do exercise tolerance test. That's called ETT. Okay, so resting is actually going to be normal. Now I have to do the exercise tolerance test in which I will ask my patient to run on the treadmill. Is it? To run on the treadmill, and while running, I will actually record their EKG. And if EKG shows me ST depression, it means patient is having what? Stable angina. Okay. All right. So that will be my stable angina being there. So if EKG shows me stable angina, ST elevation. So I will do what? After that, I will measure the cardiac markers. So will my cardiac marker elevated in the angina or they will be normal? I mean to say troponin I and the CKMB. So troponins, what will be my troponins here? They will be normal. Very good. Why?
Normal.
What's the reason? What is the reason why they will be normal? Because troponin
No
are
cellular damage.
very good. There's no membrane rupture. When your cardiac muscle membrane will rupture, they will allow the troponin to go inside the blood. Okay. So troponin I and the CKMB are going to be normal for that. All right. So that will be your stable angina. Now, how do you treat the stable angina? You treat the stable angina with the nitroglycerin. So the pain is relieved with the nitroglycerin. And how does the nitroglycerin relieve the pain? It will reduce the preload to the heart by causing the venodilation. So you get what? We know dilation. So very important to know atherosclerosis greater than 70% blockage, less than 100% blockage. Now, what will happen if I get the rupture of this atherosclerotic plaque? So I'm going to discuss now unstable angina. So we discussed the stable angina. Now we have the unstable angina. So unstable angina means patient will have what? Chest pain with the exertion as well as on the resting. So when he's resting, he also get the chest pain. That's called unstable angina. Okay. So resting plus your exertional chest pain, that's called your unstable angina. Now, what is the cause of unstable angina? You will get unstable angina due to rupture of atherosclerotic plaque. So when you get rupture of atherosclerotic plaque, rupture of atherosclerotic plaque. When you get rupture of atherosclerotic plaque, what will happen after the rupture? You will get what? Thrombosis. You know why I get the thrombosis after the rupture of atherosclerotic plaque? Can anybody tell me the reason? I already discussed with you guys in the atherosclerosis. So rupture of atherosclerotic plaque leads to thrombosis of coronary artery with very good endothelial damage. Excellent. Good job. So whenever you get endothelial damage, it's the role of the platelets to repair the defect. It's the role of the platelet to repair the defect. So you get what? Thrombosis of coronary artery. And when you get thrombosis of coronary artery, this time thrombosis, very important to know, thrombosis can lead to complete blockage of coronary artery and the incomplete blockage of coronary artery. But in case of unstable angina, you get what? Incomplete blockage, not a 100% blockage. So you get what? Incomplete blockage. Okay. So incomplete blockage will be there. And when you get incomplete blockage, it will lead to that blockage is more severe. That blockage is more severe than the stable angina blockage. So you are going to get what? Pain, chest pain with the resting as well as with the exertion, So any patient who present with unstable angina symptoms, so what you are going to do first as a physician? As a physician, first you are going to do what? You are going to do the EKG. And what will the EKG show me here in the unstable angina? Can anybody tell me what will the EKG show me in the unstable angina? Yep. EKG is going to show me what?
ST depression.
ST depression. And this time I will get ST depressions when the patient is resting. So why ST depression? Because I don't have a complete blockage. Okay, ST depression means I'm just getting the ischemia of your subendocardium or endocardial tissues. So you get ST depressions here. ST depressions will be seen in the unstable angina, and this will be seen with the resting, at resting. So any patient who have the ST depression on the EKG, what will be your follow-up test? Your follow-up test is going to be what? Follow-up test is going to be your, what will be your follow-up test? Your cardiac troponin. So what will be my cardiac troponin here or cardiac biomarkers? Anyone? They will be elevated or normal? Normal. Very good.
Normal.
Because it's angina. Angina means no muscle rupture. So troponin I is going to be normal. Excellent. So that's actually the findings you will get in the unstable angina. Okay. Now, very easy. Unstable angina is due to unstable atherosclerotic plaque. When your atherosclerotic
Sir, I always confused. Why don't we give the antithrombotic thrombolytic agent here?
thrombolytics, we give the thrombolytics antiplatelet therapy, Rahul.
Okay.
We give the antiplatelet therapy to the patients who have the unstable angina. Thrombolytics, there's a criteria for thrombolytics. We give the thrombolytics to the MI patients, not to the unstable angina patients. Okay. So better is to open the artery, better is to open the artery and yes, just put the stent because stent has a more efficacy compared to the thrombolytics. Thrombolytics do have the complication. You mean to say tissue plasminogen activator, Rahul?
Yeah, like a streptokinase.
Yeah, streptokinase we cannot give to them because of the complications and there's a reduced efficacy being there. So better is to do the angioplasty with the angiography with the angioplasty. Okay, just open the blood vessel. Just open the blood vessel before it become irreversible cell injury. That's called infarction. which I'm going to discuss. That's called infarction. Okay. So that will be your troponin I will be normal here in the unstable angina. So that was all about your unstable angina. Now I'm going to discuss one atypical type of angina that's called your vasospastic angina. Vasospastic or pyramidal angina. Vasospastic angina. It is called angina. I don't know why, because it's an atypical one. It's an atypical one angina. So vasospastic angina is, what is the reason of vasospastic angina? Is a hyperactivity of vascular smooth muscle cell. Your vascular smooth muscles are very hyperactive, like in the asthma. The pathophysiology of vasospastic angina is similar like your asthma. Okay, so you get what hyperactivity of vascular smooth muscle cell. You get the hyperactivity of vascular smooth muscle cell, and when you get hyperactivity of vascular smooth muscle cell, it will lead toward vasoconstriction. Is it? Vasoconstriction. And when I get the vasoconstriction of the coronary artery, it will lead to complete blockage of coronary artery or incomplete blockage of coronary artery. Anyone?
Complete blockage.
Excellent. It causes complete blockage. So it is called complete blockage. Then why it is called angina? It should be called infarction, is it? So it will lead to complete blockage. And when you get complete blockage, it means you get 100% obstruction, is it? That leads to 100% blockage. Is it?
But it relieves too, like it's like for short duration and that it relieves.
Excellent, very good. It's actually episodic. The nature is called episodic. So on the basis of its nature, it's very episodic. Patient might have the single episode per day. Patient might have the one episode in 24 hours. So that single episode is very short-lived. That's very short-lived. It cannot cause the irreversible myocardial injury. Myocardium can actually sustain that injury. Myocardium can sustain that injury. Myocardium can sustain the 100% blockage for 3 to 5 minutes. So that is a time period, and these episodes are very within seconds. They are very short-lived, so that's why they are called your vasospastic angina. Now, these disorders are very common in the females. Very common in the females, and they are due to the irritation. Your vascular smooth muscles are so hyperactive, they are so irritant. Once any kind of the trigger, it will stimulate the contraction of them. So what are the most common triggers for this vasospastic angina? I mean to say the stimulus triggers. So triggers or risk factors.
Maybe emotion.
Yes, very good, Rahul. Excellent. Emotions, very good. Thinking.
Cocaine use.
Cocaine use, very good. Cocaine use, very good. Drugs. Cocaine can cause the alpha-1 stimulation on the heart and on the blood vessels. Very good.
Vessels.
Remember, hypercholesterolemia and hypertension are not risk factor for vasospastic angina because the pathophysiology is not due to lipid accumulation. It's due to some hyperactivity of smooth muscle cells. So, as Rahul mentioned, emotions, very good. And smoking could be there. Smoking is actually there because smoking is irritant to the vascular smooth muscle cell. And what is the third risk factor for the, cocaine is there. Very good. And can anybody tell me some drugs which are the vasoconstrictor? They cause vasoconstriction. Which are being used to treat the MI, which are being used to treat the MI.
For
Triptan, very good.
calcium channel
migraine.
blockers.
Calcium channel blockers are the
For
treatment.
migraine.
Treatment, they are the treatment. I'm coming to that. That doesn't cause vasospastic angina. They will actually decrease the spasm because calcium channel blockers are vascular relaxation. They cause
Blockers.
withdrawal. Okay, so triptans are actually there, and any patient, not a
Pentalol.
pentalol. No. What do you want to say?
Acetabutalol and pendolol, they cause angina.
No, they will not cause this. So triptan is there, which is used for the migraine therapy. So any female, this migraine is very common in the females, and vasospastic angina is very common in the females. So any patients who have the migraine history, do not use triptan if they also have the history of vasospastic angina, or do not use migraine for the, do not use the triptan for the migraine headache if patient has an episode of vasospastic angina. Okay, so that will be your vasospastic angina. And again, we will do the EKG, ECG. So if I do the ECG, what will the ECG show me here? It will be normal or ST, or I will get some ischemic changes in the EKG. Anyone?
ST segment elevation.
Elevation, like all the time I will get the elevation? Every
ST
time?
segment.
Yeah, you're right.
No.
I will get ST elevation. You're right. Because of the 100% blockage, I might get the ST elevation. So these ST elevations will be present every time when I do the EKG, or there will be some specific time?
When
When the patient
During
when-
the
Yeah,
episodes.
when
the
symptomatic.
episode.
Very good. So there's one special type of EKG. Can anybody tell me? That's called 24-hour EKG monitoring.
Holter monitor.
Very good. Excellent. Oh, very good. Appreciate it. That's called Holter monitoring. Very good. So you do the Holter monitoring. Very good. Appreciate it. You good in Holter monitoring, and you will actually measure the 24-hour EKG, and patient will have the one episodes in these 24 hours. And during the episode, the EKG is going to show me the ST elevation. Now, how do we treat them? How do we treat them? Treatment, first you have to actually change the patient's lifestyle. If she's actually smoker, ask her to stop smoking. And other treatment will be your calcium channel blocker, CCBs, because calcium channel blockers are going to cause what? Vasodilation, and they will actually decrease the risk of the vasospasm. Can anybody tell me what is the name of anti-anginal therapy which we most commonly use for the angina therapy? Is contraindicated in the vasospastic angina. If I use that anti-anginal therapy or anti-anginal drug in the vasospastic angina, the patient might die. Beta blocker, excellent. Could you please tell me why?
I think it's beta blocker because there'll be an unopposed alpha 1 stimulation, because the beta 2 actually causes vasodilation.
Excellent.
So if you block it, it's rather.
So suppose this is my blood vessel. This is my blood vessel. On the blood vessel, I have the alpha 1 receptor. I have the beta 2 receptors. So beta 2 receptor normally causes vasodilation. Okay. And when the epinephrine binds to beta 2, it will cause what? It will cause vasodilation. Now what if I block the beta 2? The epinephrine will go to the alpha 1 receptors. So epinephrine will stimulate the alpha 1. So I will get what? Unopposed alpha action. And when I get the alpha 1 action, I will get the vasoconstriction. So patient might die of the episodes because of the unopposed vasoconstriction happening. Normally there's a balance between alpha 1 activity and the beta 2 activity. So it leads to normal lumen of the arteries. Okay. So that's very important. Good job. Very good. So that's all about your angina. Okay. Now, if I don't treat the angina, anybody have question regarding angina before I jump into the infarction? Okay. So if I don't treat the angina, it's going to cause what? It's going to give me the infarction. So infarction is actually called your irreversible cell injury. So I for infarction, I for your irreversible cell injury. Infarction. So myocardial infarction is actually going to happen. It's called irreversible cell injury. Now, irreversible cell injury is actually characterized by what? It is characterized by, so what is the cause of irreversible cell injury? The cause of irreversible cell injury is called 100% blockage. 100% blockage of coronary artery. So when you get 100% blockage of coronary artery, it leads to complete blockage. And that is going to reduce what? That's going to reduce your ATP. Lot of the ATP will be reduced. So your membrane swelling continues. And if you don't treat that membrane swelling, what stage will come? You will get the rupture of the cell. And rupture of the cell is a characteristic feature of irreversible cell injury. So can I say like this? Infarction is characterized by the rupture of the myocardial cells, rupture of the cells. And can anybody tell me what is the cause of your 100% blockage of the coronary artery? Yep. Cause of the 100 atherosclerosis was actually partial blockage. Thrombosis, excellent, very good. Thrombosis. So when you get rupture of the atherosclerotic plaque, you will get what? Thrombosis. And that thrombosis is going to do what? That thrombosis is going to completely block your myocardial cells, completely block your, blood supply to the myocardial cells, and you get the irreversible cell injury. Now, this is called myocardial infarction. So, depending on the EKG changes and depending on the pattern of the ischemia, we have the two types of the myocardial infarction. So, one is called STEMI and it's called anastomie. So, we are going to discuss the anastomie first. Anastomie. Anastomie means non-ST elevation. There will be no ST elevations in the EKG, but it is still MI. So anastomie is actually what? You get the 100% blockage, and that 100% blockage is that causes what? That causes the ischemia of the last layer of the heart, most vulnerable part of the heart. And do you know most vulnerable layer of the heart, which is most likely to get the ischemia, is called what? Pericardium, myocardium, or endocardium?
Endocardium.
Endocardium. Why? So it's going.
Subendocardia.
Yeah, it's called
Subendocardium.
yeah,
Subendocardium.
very good, very good. More specific, more precise. I like your approach today. Very good, Latif. Okay, so this is actually ischemia of subendocardial space, subendocardial cells or subendocardial cells. And why we get the subendocardial cells being affected first in the myocardial infarction? Because yeah,
because in the endocardium we have blood in the ventricle, and we have aortic artery in the pericardium, in the epicardium. So
very
the
good.
one the farthest from epicardium is the subendocardium.
Very
The
good.
endocardium is touching the blood in the ventricle, so it gets a nutrient.
Excellent. Very good. Very good. Very good. So pericardium, coronary artery enters into the heart in the pericardium. So first they will give blood to the pericardium, then myocardium, then endocardium. So that is why endocardium is more likely to be affected first. So when you get subendocardial infarction, that's called non-ST elevation MI. Okay. So that's actually, in the EKG, you are going to get what? In the ECG, you will get what? You will get ST depressions. So ST depression means your subendocardial ischemia. Okay. So if I will do the cardiac biomarkers here, they will be elevated or normal. So I get ST depressions here. So what will happen to my cardiac biomarker? Troponins will be elevated because it's a MI. It's a MI, and the hallmark feature of MI is what? Irreversible cell injury, which is called rupture of the cells. Okay. So that's called the non-ST elevation MI. Now we have the ST elevation or STEMI guy. STEMI. ST elevation MIs. So ST elevation MI, the reason is same. You get 100% blockage secondary to the thrombosis of the coronary artery. But this time, this thrombosis is very, I would say, long-term, or it's not being treated, which leads to the ischemia or infarction of all three layers of the heart. So when you get infarction of all three layers of the heart, it's called transmural infarction. Infarction of three layers of the heart. Of the heart. Okay. So when you get the infarction of all three layers of the heart, it's called ST elevation MI. ST elevation MI. And EKG will show me obviously ST elevations, and I will get what? I would say troponin will be obviously elevated. So that's called your, that's resting EKG is going to show me the changes. All right. So that was all about your MI, myocardial ischemia, and the difference between ST elevation and the non-ST elevation MIs. All right. Now we will discuss I would say, the changes happening with the time. How the MI is actually getting evolved, how the MI is getting evolved with the time. So evolution of MI with the time. So that's very important one, evolution of MI. Okay. So we are going to discuss now evolution of MI. So what changes are happening from 0 to 4 hours, then from 4 to 24 hours, and then from your 24 hours to 72 hours, and then onwards. So evolution of MI, evolution. How does the MI evolve? Evolution of MI. Okay. So before I go into the evolution of MI, can anybody tell me the symptoms of the MI? How does the patient actually present? Symptoms of the MI. Yep. What are the symptoms of the MI?
Diaphoresis, correction, chest, retrosternal pain.
Yeah, very good. Retroesternal chest
Radiation of the pain.
pain. Severe retroesternal chest pain. Very good. That radiates to that radiates where?
The left arm, chin, back, neck.
Very good. So that actually radiates to the left arm or the jaw. And can anybody tell me the name of the nerve which carry the pain of MI to the left arm? Yep, that's called left intercostal brachial artery. Intercostal means it's getting sensation from the heart area. Brachial means what? Brachial means the upper arm. Brachial means the upper arm. So it's very easy. Left intercostal brachial artery do what? It carry the sensation from this area, and this nerve is actually responsible for the radiation of the MI pain. Left intercostal brachial. Left intercostal brachial artery. Okay. Left intercostal brachial nerve. Okay. All right. So that will be your carrying this. Now, you guys mentioned that you will get the vomiting, nausea, sweating. Can anybody? Yes, nerve. Sorry, my mistake. My bad. Okay. So it's actually nerve. So you also get the sweating. You also get the nausea. What's the reason of this? Can anybody tell me why I'm getting this excessive sweating and diaphoresis, nausea, vomiting in the MI patient? What is the reason of that? The reason of that is actually due to the irritation of the vagus nerve. Do you guys know that the vagal? Very good. Excellent. So vagus nerve is running very close to the heart. It's very close to your heart. And when you get the MI in the heart, it means inflammation is going in the heart. And that inflammation is going to do what? It's going to irritate the vagal nerve. Irritate the vagal nerve. And that when you irritate the vagal nerve, you're going to get what? Nausea, vomiting, and the sweatings will be seen. Okay. So that's the symptoms of the MI. And do you know most commonly blocked coronary artery is what? What's the name of the most commonly blocked coronary artery? It's called left anterior descending artery. Left anterior descending is first. Then you get the right coronary arteries. Then you will get the left circumflex artery. So I will discuss the symptoms of every artery in the details with you when I discuss the EKG lead. So let's discuss the changes happening. So what changes will happen in the myocardium from 0 to 4 hours? So if my blockage is happening from 0 to 4 hours, so from 0 to 4 hours, what I will get in the myocardium I'm discussing
No changes.
No changes. Excellent. So myocardium, there will be no rupture. You cannot say no changes. You can say that changes will happen, but these changes will be reversible changes. Reversible. And what does mean by the reversible? Means you get the cellular swelling, you get the water accumulation. Water get accumulated within the myocardium. So if your water get accumulated in the cardiac muscles, and when I do the histology of cardiac muscles, how will they look like? They are going to look like your wavy fibers. Wavy fibers means they are full of the water. Is it? Wavy fibers. So from 0 to 4 hours, what will my histology change? Histology is going to show me, you guys are right. On the gross examination, the myocardium is going to look normal. But when you do the histologic examination, that's going to show you the wavy fibers which are full of the water, completely full of the water. All right, so that will be the changes you are getting from 0 to 4 hours. That's actually called 0 to 4 hour reversible changes are happening. But what will happen if your injury continues from 4 to 24 hours? 4 to 24 hours, you will get what? You will get the infarction or irreversible cell injury. And do you guys know there are two types of the irreversible cell injury? Necrosis and the apoptosis, which we will discuss in the general pathology. We will discuss in the general pathology. So that is called necrosis or apoptosis. So you guys know that ischemia or reduced blood supply to every tissue of the body will lead to coagulative necrosis. It causes coagulative necrosis. It causes coagulative necrosis to every tissue. except one tissue in which the ischemia or reduced blood supply will not lead to coagulative necrosis, but it will cause liquefative necrosis, which is called your brain. And could you please tell me what's the reason, Huzi or Latif, why brain does not have the coagulative necrosis? Why brain have the liquefative necrosis?
It's from the fat. So fatty necrosis will happen if it's
No, fatty necrosis is different. Liquefative necrosis is different. Very good. Enzymes. Microglial cells. Microglial cells are responsible for the liquefaction of the brain matter. When your brain tissue is actually getting ischemia, you will get. So coagulative necrosis, can anybody tell me what are the characteristics of coagulative necrosis? So you will get the nucleate changes as well as the cytoplasmic changes. So what nucleate changes you are going to get here? You will get what? Karyorrhexis. Yep. So you get first you will get the fragmentation of nuclear material, then these fragments will break down. So you get karyorrhexis and the karyolysis. Karyolysis is going to happen. So these changes you will see in the myocardium within the nucleus. But what changes you are going to see in the cytoplasm? Very good. So first you get karyorrhexis, then you get karyolysis, then you get the pycnosis. Pycnosis means you get the complete shrinkage of the nuclear material. You know, what's the feature of necrosis? Necrosis means you get the loss of the nucleus. Loss of the nucleus means necrosis. So you get three changes in the nucleus. First is called your karyorrhexis. Karyorrhexis means nuclear changes will be condensation. You get a condensation of chromatin material, that's called karyorrhexis. And that karyorrhexis will lead to what? Karyolysis, which is called the fragmentation of the condensed material. And once your condensed material get fragmentation, you will get what? Pycnosis, complete shrinkage. So that's the nuclear changes. But what changes you will get in the cytoplasm? Obviously, edema of the cytoplasm. Edema of cytoplasm. Okay, edema of cytoplasm will be seen because you get a lot of the fluid coming into the cell. So edema of the cytoplasm is going to be seen. Okay, so what complications can happen during this 4 to 24 hours? Very important to know what complications patient can get during this period of the MI. So any patient who's having the MI from 4 to 24 hours, you know, what complications you are going to get. So one complication, you will get what? You are going to get the ventricular arrhythmias. Can anybody tell me the reason of the ventricular arrhythmias? Why do I get the ventricular arrhythmias in a patient who have the MI from 4 to 24 hours? And that is a cause of sudden cardiac death we see most commonly in the practice, ventricular arrhythmias. Can anybody tell me the reason of ventricular arrhythmias? Why do I get the ventricular arrhythmias in these patients? Yep. The reason of ventricular arrhythmia, very good, excellent, good job, very good. So reason of ventricular arrhythmia is what? You know, what is the pathophysiology of the MI? You get the failure of sodium-potassium pump. And when you get the failure of sodium-potassium pump, what will happen to the blood potassium level? Your blood potassium level will increase, is it? Because normally sodium-potassium pumps do what? It brings the potassium into the cell. So if your potassium pump is not working, your potassium will remain outside in the blood. So your potassium increase in the blood. And when you increase the potassium in the blood, you get what? You get the ventricular arrhythmias. Because you guys know that changes in the potassium will lead to changes in the heart function. Changes in the sodium level will lead to changes in the brain function. So potassium is a very important ion for the heart. Okay. So you get what? So very important to know, if you get the ventricular arrhythmias after 24, before 24 hours of the MI, it is due to electrolyte disturbance. It's not due to the stasis of the blood. It's due to the electrolyte disturbance. So you get one complication, that's the cause of sudden cardiac death. That causes sudden cardiac death. Okay. What will the other complication you are going to get in the patient? Yes. So other complication, obviously you will get the heart failure. And if this heart failure is very severe enough, you might get the cardiogenic shock. So these complications can happen from 4 to 24 hours. Now, there's a one complication which can happen during this period, and that's a complication secondary to the therapy. Secondary to therapy, that's called reperfusion injury. Reperfusion injury. Can anybody tell me the mechanism of reperfusion injury and why does the reperfusion injury happens between 4 to 24 hours or from 0 to 24 hours, reperfusion injury. Reperfusion injury is very common during this phase, during this time period. Yep.
Because of free radicals.
Very good. Excellent. Because of what is reperfusion? What is reperfusion? First, reperfusion therapy is what? I'm trying to open the block blood vessel. So when I restore the blood flow to the myocardium, it's called reperfusion. So when I restore the blood to the necrotic myocardium, what is going to happen in the necrotic myocardium? Already, inflammatory changes are going on. Inflammatory changes are going on. So what will happen when I increase the blood flow to the myocardium? I also increase the oxygen supply to them, increase O2 supply. And when I give O2 to the necrotic tissue, which is being surrounded by inflammatory cells, what will the inflammatory cells do? Inflammatory cells will convert this oxygen into free radicals. And when they convert this oxygen into free radicals, these free radicals, superoxide ions, hydrogen peroxide. So these free radicals will actually further damage your myocardium. They will further damage your myocardium. So that is called your reperfusion injury, which is a complication of the restoration of the blood flow to the myocardium. All right. So these are the changes which are happening from 4 to 24 hours. Okay. Now we will discuss the changes after 24 hours to your 72 days, 72 hours. So from 1 to 3 days, 24 to 72 hours. So 24 to 72 hours. So you guys know that once your 24 hours are completed, it means coagulative necrosis phase ends. So this is the ending of the coagulative necrosis. So coagulative necrosis will end after 1 day. After 1 day. So you guys know that necrosis is always followed by what process or what step? Necrosis will always be followed by what?
Inflammation.
What inflammation? Acute or chronic?
Acute. Acute.
It will be your acute inflammation. So necrosis will leads to what? It always leads to acute inflammation. And why? What's the reason? Why the acute inflammation always
because the debris has to be cleared by
excellent. So you have to remove the dead tissue and replace it with the scar tissue. Is it? If you don't remove the dead tissue, you cannot fill in the gap or you cannot produce a scar tissue. So first you have to do what? Remove that dead tissue from the myocardium or heart. So acute inflammation will follow. So you guys know that the most important cell for acute inflammation is what? It's called neutrophils. So from 1 day to 3 days, you will see neutrophilic inflammation within the heart. Neutrophilic inflammation within the heart. You get neutrophilic inflammation. Okay. And that neutrophilic inflammation will do what? It will try to clear the dead tissue. Clear the death tissue. You're trying to remove the dead tissue, is it? You're trying to remove the dead tissue, and that clearance of the dead tissue will provide a platform for the regeneration. So that's the role of the neutrophils. So neutrophilic inflammation, you will going to see. So from 1 to 3 days, if I do the histology will show me what? Histology is going to show me the extensive coagulative necrosis, plus you will see the neutrophils surrounding the dead tissue. So if you do the biopsy of the myocardium, you will see what? Neutrophils surrounding the dead tissue or infarct tissue will be seen. Okay, and the gross picture is obviously going to show me the very hyperemic borders or hyperemia because of vasodilation, inflammation. So what complication, that's important to know, what complication you might get between this period. Yep.
Pericarditis.
You might get what? You might get the pericarditis. And what's the name of that pericarditis? That is called peri-infarction. Peri-infarction. Peri-infarction, fibrinous pericarditis. Why it is called peri-infarction? Peri-infarction. Yes. The term peri-infarction means that pericarditis will be localized around the dead tissue. So that will be the localized pericarditis, and that pericarditis is very close to the dead tissue. Very close, that's localized. So that's why it's called peri-infarction, surrounding the dead tissue. Peri-infarction, fibrinous, because we get the diffuse pericarditis, which is called Dressler syndrome. I will discuss that. And that complication happens after 2 weeks of the MI, 2 to 6 weeks or 2 to 8 weeks. So peri-infarction fibrinous pericarditis. And what is the reason of this peri-infarction fibrinous pericarditis? The mechanism is actually what? When the neutrophils come to the heart, their primary job is what? Their primary job is to clear the dead tissue. And in doing so, some of the neutrophils will do what? Some of neutrophils will extend into the pericardium. Some of neutrophils will extend into pericardium. And when they extend into the pericardium, what will they do? They will induce the inflammation in the pericardium. So this is very quick process because neutrophils are so quick. So they will actually quickly induce the inflammation. So any patient, if they mention that, any patient like 56-year-old patient have the MI 2 days ago. Now he's complaining of the chest pain, and he said his chest pain increases when he do the inspiration, and it get reduced when he leans forward or sitting upright. So what is the cause of this acute pericarditis in this patient? It will be called peri-infarction fibrinous pericarditis, which is actually the extension of neutrophils into the pericardial cavity. Okay, so that will happen from 24 hours to 72 hours. Now, what will happen from 3 to 7 days? 3 to 7 days. Can anybody tell me what is going to happen? So after neutrophilic inflammation, what cells will come, which are called the supervisor cells? They're going to supervise the work done by your neutrophils, how the neutrophils have completely cleared the dead tissue or not. So that will be called that's called the macrophages. So macrophages will come and will look after, or I would say they are going to see the work done by the neutrophils. And if they see that neutrophils have did a brilliant job, neutrophils have completely cleared the dead tissue, completely clear the dead tissue. If they see that neutrophils have completely cleared the dead tissue, then what will they do? They are going to start the process of healing. So before starting the process of healing, what will they do? They have to suppress the inflammation. They are going to suppress the inflammation, because if they don't suppress the inflammation, your healing process cannot be initiated. Okay, if both processes are happening at the same time, you will not get the net result. So first you have to stop the inflammation, then you have to start the your healing process. So can anybody tell me what interleukins macrophages will release, which will stop the inflammation, which will actually ask the neutrophils to do not come now. You have did a brilliant job, and there's no need to come again. Okay.
Interleukin 10.
Very good. IL-10 is there. Excellent. And other is called TGF beta. Excellent. Interleukin 10 plus TGF beta, transforming growth factor beta. Okay, so that TGF beta, and these will actually do what? They will stop the inflammation. And once they stop the inflammation, what will the macrophages release now? Macrophages will release the fibroblast growth factor, and that fibroblast growth factor is going to do what? It's going to call the fibroblast to come and take the charge. So it's your role now. Okay. So during 3 to 7 days, if I do the biopsy of myocardium, I will only see the mononucleate cells, or I will see the smaller cells that your macrophages will be seen during this period. Okay. Now, very important to know the complications happening during this period. Okay, so before I jump into the complications, so did you guys understand after 7 days your healing process is going to start? I'm going to discuss that. Okay, so now what if your neutrophils have not completely cleared the dead tissue? They have cleared the dead tissue partially. Still 50% of dead tissue is remaining. So what will the macrophages do then? Macrophages will do what? They will actually, they will clear the dead tissue itself, or they will call the neutrophils to come again and clear by yourself. Yep. Very good.
By their self.
Very good. They have to call the neutrophils to come again, because the job of neutrophils, it's not a job of supervisor to do your work. You have to do your own work. So they will call the neutrophils to come, and how does they, what interleukin they will release to call the your macro neutrophils to come again. Yep. So what interleukin they will release? Very good. MS said some interleukin. Very good. What is the name of that? That's called interleukin 8, IL-8. IL-8 is a chemokine for the neutrophils. Okay. So they are going to release the IL-8, which will actually call the neutrophils to come again and do your job. All right. So what complications you can get during this phase? Complications. So if your macrophages are within the myocardium, your macrophages are coming. You guys know that macrophages are professional phagocytic cells. They can eat the normal tissues as well. Okay. So macrophages can do what? Macrophages can eat your papillary muscles. So if they eat your papillary muscle, you will get what? You will get mitral regurgitation, MR. So any patient who present with the holosystolic murmur at the fifth day of the MI or the 7th day of the MI suspect mitral regurgitation due to the rupture of the papillary muscles. And most commonly ruptured papillary muscles are what? They are posteromedial or anterolateral. What papillary muscles are more?
Anterior.
Posteromedial.
Why? Posteromedial. I told you in the blood supply. Why? What's the reason why posteromedial is there?
Because the blood supply is just one, the PDA that supplies it.
Very good. So in the posteromedial, I have the just single blood supply, whereas anterolateral is supplied by dual blood supply. That's called left anterior descending artery and the left circumflex artery. Okay. So posteromedials are already weakest muscle, and macrophages love to target the weaker tissues. Is it? It's very easy to kill the weaker person. Okay. All right. So that will be your papillary muscles being the, so you get the mitral regurgitation. What if your macrophages actually rupture your interventricular septum? If it ruptures your interventricular septum, you will get what? Interventricular
VSD.
VSD. So how it will present in the patient? So patient after 5th day of the MI or 6th day of the MI might have the VSD. So that VSD is going to present in the holosystolic murmur. No cyanosis. What? No, Latif. Because VSD is what? VSD is actually your left to right side. Okay. So it's going to present the holosystolic murmur in the tricuspid area along the left external border. That will be harsh holosystolic murmur. I would say harsh because sound is very high. You get the harsh at the tricuspid area. Very good, Latif. Excellent. So that will be at the tricuspid area. You will hear the harsh, and your oxygen saturation start to rise up in the right ventricle, not in the right atrium. I already discussed that VSD with you guys. Okay. Now, last complication which you can get during this phase. During this phase, you are getting all phagocytic complication. They're all phagocytic complications are happening. Okay. So during this phase, you will also get another phagocytic complication. Your macrophages can rupture the left ventricular wall. Rupture left ventricular wall. And once they rupture the left ventricular wall, you will get what? You will get the blood leakage into the pericardial space. And when your blood is accumulated in the pericardial space, you will get cardiac tamponade. And can anybody tell me the presentation of cardiac tamponade? How will they actually say that patient on the 5th day of the MI or after 5th day of the MI Here the cardiac tamponade. So back stride. Could you please tell me what's a back stride?
So there is muffled heart sounds. There is increased jugular venous pressure.
Muffled heart sound. Muffled heart sound is not a component of back stride. Muffled heart sound is actually your physical examination finding. So back stride is actually composed of hypotension, decreased blood pressure, raised JVP. Yeah, you're right, muffled. Sorry. Okay, I'm actually tired. Okay. So I cannot challenge you today. Okay. All right. So that will be your muffled heart sound as well. Decreased heart sound could be there. Okay. So that's actually your back stride for you. Okay. All right. I'm sorry for that. My bad. Okay. So that will be the back stride you will get in these patients. All right. And then the cardiac tamponade, you also get pulsus paradoxus. We will discuss that. Okay. So that will be your, 3 to 7 days. And tomorrow we will discuss what happens after 7 days and the 14 days. And from 14 days and onwards, because complications are there. I don't want to finish the Dressler syndrome in the quick, because Dressler syndrome, I have to discuss the pathophysiology with you guys. Okay. So I'm sorry, I'm actually feeling a little bit tired today. And we can actually stop here, and tomorrow we can continue from here. And tomorrow we do the arrhythmias. We do the arrhythmias, and then we do the other shocks. Okay. Anybody have any question?
Sir,
Yes, Archana.
sir, could we please extend the class duration from 1 hour to 1.5 hours, if possible?
1 hour to 1 hour. What should I explain?
Could we please extend the class duration, sir, if it is possible?
Past duration? What I don't. What you are trying to ask? I cannot.
No, sir. I would like to ask, uh, could you please extend the class duration?
Class duration tomorrow or today?
Yeah.
We did, I think, 1 hour and the 10 minutes we did. So tomorrow I think it will be 1 hour. I think. Okay. So I will actually confirm in the group. Okay. I will confirm
Okay,
with
sir.
you guys. Okay. All right. I will confirm with you. Okay. Okay.
Okay.
Anybody have any question? Everything good? All
Yeah,
good?
everything is good, sir.
Okay. So thank you for coming, and I see you guys tomorrow. Bye bye. Take care.